Thank you all for being here, either in person or joining virtually. Today I'll be talking about behavioral and neuroanatomical predictors of long-term outcomes in aphasia. So one thing to note about this talk is that I'm presenting some data that this is the first time I've actually presented it, so I welcome some suggestions, comments, and questions at the end of the talk, but I'm excited to show this work today. So to begin and to set the stage, the global burden of stroke is on the rise. So it's estimated that there are approximately 33 million individuals living with stroke worldwide. And as mortality rates decline, survivors could reach 70 million by 2030. And I have these figures at the bottom of the slide here. On the left, it shows prevalence of stroke survivors per 100,000 individuals in 1990. And on the right here, it's prevalence in 2005. And you can see the United States obviously is in red in both cases, but you can see that the actual numbers are increasing within that 10-year span. And this also goes for other countries. So some countries in Europe and Asia, you can see Russia and some European countries, their stroke incident or prevalence rates are actually on the rise as well. So this is a global trend. And there's also been an epidemiological shift in stroke occurrence. So ischemic stroke rates have actually been decreasing in older individuals, so those aged 65 and over. But stroke is actually increasing in younger individuals. For example, one study showed individuals between 45 to 64. Specifically in the Kentucky and Cincinnati region in the United States, there's been a reported increase in stroke incidence in individuals as young as 20 to 44. And this appears to be a global trend. So in Denmark, between the years of 1994 and 2012, there was a reported increase in those 15 to 30 years old. And there's a similar trend in France and Sweden. And it's been attributed to factors such as some lifestyle factors, increasing smoking rates or drinking, pollution, but many of these are cryptogenic. So many of these, it's not known why stroke rates are increasing in younger individuals. So what does this changing burden of stroke mean for aphasia rehabilitation? In the United States today, 1/3 of all strokes cause aphasia, and it's estimated by the NIDCD that there are 180,000 new cases per year. National Aphasia Association currently suggests that there's about 2 million people living with aphasia. And so what this means, as individuals have stroke younger, there are more stroke survivors living longer with aphasia. And so this, obviously, we know as clinicians and researchers, that the return to pre-morbid activities of daily living, jobs, social aspects, hobbies are really important for individuals' quality of life. So therefore, it's imperative to understand these long-term outcomes in aphasia recovery. And as clinicians and researchers, can we assume that there's this plateau in chronic abilities? And really, what does living longer with aphasia mean for recovery and treatment? So we know that the greatest changes in recovery are seen acutely for both spontaneous and treated recovery. Language changes are assumed to be relatively static after 1 year post-onset. So I have this figure here from Laska and colleagues, and on the, pointer's not showing up here. You can see on the x-axis of this slide, acute stroke to 18 months post-stroke, and you see this drastic incline in ANELT scores. So ANELT is the Amsterdam-Nijmegen Everyday Language Test. You see this drastic increase in scores in those first 3 months, and then they do plateau over time. Roby has also suggested that this plateau occurs between 6 to 12 months. And unfortunately, there's been little research really investigating aphasia outcomes after 1 year. Many studies that do exist have small sample sizes or single case studies. However, in 2017, there were 2 papers published that I'll talk about in a little bit more detail to really set the stage for this talk today. The first is a behavioral study by Audrey Holland and colleagues looking at change on the Western Aphasia Battery, the WAB, aphasia quotient, so the WAB-AQ. And the second is a study by Thomas Hope and colleagues looking at changes in naming performance and changes in the right hemisphere that may actually predict these long-term changes. So the first study by Holland and colleagues, they obtained data from the Aphasia Bank. So for those of you who may not be familiar with the Aphasia Bank, it is an NIH-funded project where individuals who study aphasia, so aphasia researchers from all over the US, contribute data. So this includes testing data as well as video recorded speech samples and testing from individuals. So this data is all shared, and approximately 20 sites have contributed data, and there's data available from over 300 individuals at least one time point. But what Holland and colleagues did is they looked for individuals who had multiple, or at least 2 tests in the Aphasia Bank database. They identified 26, And at test 1, again, all individuals are in the chronic stage. Mean time post onset of stroke was 5.5 years, with a pretty big range, so about 6 months to 15 years. And then mean time post onset of stroke at time 2 test ranged about 2 to 20 years. So they took the WAB-AQ scores of these individuals and they grouped individuals by change. So they looked at any individual whose WAB-AQ changed at least 3 points, so plus 3 points or minus 3 points, either direction. They chose this 3-point change. So again, for those of you who may not be familiar with the WAB, it is the WAB-AQ is a 100-point scale. Standard error of measurement is a 2.5. So they rounded up to 3, suggesting that they discuss extensively in their paper that individuals would have to make some pretty extensive gains or declines to actually meet this 3-point change. So looking at their sample, they had 62% of individuals actually improved over time. And again, mind you that this is in the chronic stage and in some cases, many years post-stroke. 27% maintained and 11% declined. They found that these declines did not correlate with age or time post onset of stroke. And they also showed that those who improved on the WAB improved on other tests. So for example, the Boston naming test and the verb naming test. So now looking at what neural predictors might be driving this, Hope and colleagues looked at 28 individuals from their PLORUS database. So all individuals that had been tested at least 1 year post-stroke. Mean time of test at first, or mean time post-stroke at first test was 50 months, and at time 2 was 80 months. All individuals had neuroimaging data available from the testing time points. So they had MRI data that was either acquired at the same day that the behavioral testing was done, or within a very short time span. So they did voxel-based morphometry analysis or VBM analysis. Their dependent variable was changes in naming from the comprehensive aphasia test. So similar to Holland and colleagues, they did show here on the left that a number of individuals improved. So they had 13 people improve, 11 declined, and you can see those individuals in red, in some cases very steep declines, and then the rest maintained, and you can see those in black. So looking at correlating structural change with the rate of behavioral or naming change, they found two important areas. So they had a peak in the precentral gyrus where increase in gray matter was actually associated with a decrease in naming performance. And they found there here in red this positive correlation between increase in gray matter in the middle temporal gyrus and improved naming. So from these two studies, we see that the chronic stage is indeed dynamic, especially years post-stroke. Improvements are just as likely as declines, and Hope and colleagues showed this with a Bayesian analysis of variance. Changes may be mediated by something other than age and time post-onset, according to Holland and colleagues. And it might be that some changes in the right hemisphere are a factor. So what we learned from these studies is that the idea of a plateau is indeed a myth, and we really need to investigate this in long-term aphasia recovery. So some remaining questions, and these are going to set the stage for the rest of this talk and the research I'll be presenting today. First, how do variables related to health status affect long-term outcomes? What role does the damaged right or left hemisphere play in recovery? So some work by Dr. Fridriksson has showed that the integrity of perilesional tissue is really important for long-term outcomes. And 3, do markers of brain health predict long-term outcomes? So white matter hyperintensity changes or leukoariosis. So the next few slides, I'll go over just some general methods. So for this study, we queried our database to determine how many participants had testing at multiple time points. So this was a retrospective chart review over about 10 years worth of data from the University of South Carolina and the Medical University of South Carolina. Our inclusion criteria were based on individuals who had 2 or more Western aphasia battery tests at least 6 months apart and at least 6 months post-stroke. So do keep in mind we didn't use the WAB as an outcome measure in any study. So it's not just that people have multiple WABs because they've done multiple studies and we've given it as an outcome measure. All individuals, or not all individuals, but we preferred neuroimaging at each WAB time point, but that was not necessary. And I'll talk about that a little bit later when I talk about the neuroimaging data. We excluded any individual that had concomitant neurologic impairment affecting the brain, multiple strokes, right hemisphere damage, or TBI, and anybody 85 years or older. So we obtained we had 41 individuals who met these criteria, 28 males and 13 females. And I have some of their demographic information listed here. So we did look at age, education, treatment hours, exercise pre-post, and also antidepressant use in individuals who had been diagnosed with diabetes. So one thing I do want to explain on this slide, treatment hours estimated. We only included treatment hours from individuals who had participated in treatment studies here in the Aphasia lab. So we looked at cumulative hours spent in treatment here. So this does not include hours that individuals may have received treatment either in acute stage or long-term rehab. So this is probably an underestimate of total treatment hours that some of our individuals have had, but this was the best way that we could quantify. So 28 individuals had only 2 WAB administrations, but you can see here that there were some participants who had more than 2 WABs administered. Again, these were not these WABs were not obtained from an outcome measure. We had some individuals with 3 or 4. We had one individual with actually 7 WABs. So mean months post-stroke at initial testing was 36 months. So everybody is indeed in the chronic phase, and in many cases years post-stroke. And at final testing, 76 months. Initial AQ severity is 53, so that's pretty mild to or moderate to severe WAB AQ score. Our initial classification here, the majority of our individuals did have Broca's aphasia, again as determined by the Western Aphasia Battery, and we had all other subtypes represented, however not enough in each different classification or different category to look at kind of changes by different aphasia types. So we grouped every individuals as improvers, individuals who declined, and those who remained stable. And we used that same 3-point WAB AQ criteria that Holland and colleagues used. We found that 21 individuals actually improved, 10 decreased, and 10 remained stable. So when looking at baseline WAB AQ scores for the individuals in each of these groups, we find that there were no significant differences in baseline AQ. The individuals who improved did tend to be more severe than the other 2 groups. However, that was not a significant difference, and that's actually something that Holland and colleagues found in their sample as well, that their individuals that improved tended to be more severe at baseline. When looking at just change from first to last WAB assessment, there was a main effective group. You can see the dark blue are the individuals who improved, and their improvement, their change scores were significantly greater than those who declined and those who maintained. However, there was no significant difference between those who declined and those who maintained. So this is just another way to visualize all of the individuals in the behavioral sample. So let me walk you through this graph. On the x-axis are the number of assessments, or the assessment number. So from 1 to that one individual that had 7 assessments. And on the y-axis are the AQ scores. Each line corresponds to each participant's test. The color coding really just helped us to distinguish between different participants. And the circles correspond to treatment hours. And so this is actually cumulative treatment hours. So I'm not sure if my pointer is showing up there, but this very first line here, you see at baseline, this individual had no treatment, but then at their second test time, they had 25 hours, and then they didn't receive any more treatment. So it was actually just 25 hours of cumulative treatment over those 3 assessment periods. But what I want to point out here is that we do have a lot of individuals improving, and as well we have individuals declining, and in some cases over repeated WAB assessment. And this is some work that Lisa Johnson is currently writing up for publication. So I wanted to thank her for use of these figures here. So next what we wanted to do is to actually predict what's driving some of these changes. All WAB AQ scores were included in a linear mixed effects model predicting change in AQ severity scores. We entered the following factors: stroke age at testing, sex, the diagnosis of diabetes, just yes or no, time post-stroke of WAB testing in months, education, fluent versus non-fluent aphasia type. And again, we couldn't look at each individual subtype because we didn't have enough representation across all aphasia types. Amount of post-stroke exercise, so number of days a week where an individual exercised 30 minutes or more. We looked at months between repeat WAB administrations, and cumulative treatment, or the treatment that they received within the lab. So first I'll go through what was not significant for these results and then discuss the significant findings in detail. So we didn't find an effect of gender, education. There was no main effect of exercise or diabetes. There was no difference between fluent or non-fluent type of aphasia. And again, that's classified by the WOB. No main effect of interval between testing and no effect of time post-stroke at test. We did, however, find a significant effect of age. So we found that as individuals decreased or increased in age, their WOB scores did tend to decrease. We did find an effective treatment. So this was a positive finding. So every 1 hour associated, or every 1 hour of treatment was associated with a 0.06 point increase in AQ. And just to remind you, mean treatment hours, at least from those who participated in treatment studies here, was 33 hours, 33 hours. So interestingly, diabetes and age, there was an interaction that trended towards significance. So you can see here age on the x-axis and WOB-AQ on the y-axis. Those with diabetes are in this kind of bluish, greenish color. As those individuals increased in age, their rate of decline in WOB-AQ was actually a little bit steeper, but that did not reach significance. It was close. We did, however, find a significant interaction between diabetes and amount of exercise post-stroke. So here again, you see in this kind of green color, individuals with diabetes. So those who did exercise tended to show a greater increase in WOB-AQ scores compared to those that did not have diabetes but also did exercise. Their AQs were relatively stable, or that was a relatively stable effect on their AQ change. And so to summarize the behavioral data before getting into the neuroimaging data, we saw a significant effect of age, treatment, and exercise for those individuals in our study that had diabetes. So next, I'll be looking at the role of perilesional integrity and how this may affect change. So do changes in perilesional white matter and gray matter volumes affect outcomes? I do want to point out here that 3 of our individuals from the prior sample, the behavioral data sample, did not have neuroimaging. So I'm only presenting data from 38 individuals here. This is a lesion overlap map from all of these 38 individuals. And you can see in red are areas of the greatest lesion overlap within the insula, IFG region, and superior temporal gyrus. So to obtain gray matter and white matter volumes, first lesions were drawn on T2, and then the T1 and T2 were co-registered with the lesion sliced to T1 native space. Normalization parameters were then applied to each time 1 T1 scan using SPM's unified segmentation normalization procedures. And the time 2 scans were segmented and co-registered with these same parameters. And then from here, what we did was the lesions were dilated 5 millimeters. So you can see in red here on this slide, that's the lesion dilation mask right there. And then the original lesion was subtracted. So original lesion is here in blue, and that resulted in this 5 millimeter shell, kind of the space between the dilated lesion and actual lesion, where we obtained gray matter and white matter volumes. So from there, we obtained difference measures of gray matter differences and white matter differences by just subtracting the time 1 volumes from the time 2 volumes. So just to illustrate some of the changes over time, the change in gray matter between scans is actually not significant. So you can see here on the x-axis, this is just change scores. So 0 obviously corresponds to no change. Most individuals were on either side of 0. However, there was a significant change in white matter between scans, in which case many individuals did actually decrease. So you can see here, 0 is no change, and then a lot of individuals actually had decreased white matter volumes at time 2 scans, and that was significant. So next we correlated, used two-tailed correlations controlling for intracranial volume at time 1 and scan interval at months. Gray and white matter changes, notably, were actually not correlated with lesion size. So lesion size didn't seem to affect change in gray matter and white matter or perilesional changes. Change in gray matter was actually positively associated with treatment hours. So the more treatment an individual got, more perilesional gray matter tended to increase, positive direction. Increase in white matter was positively associated with change in informational content. But we didn't see any significant correlations between change in gray matter and WAB-AQ or any of the subtests for both perilesional areas and those restricted to the dorsal and ventral stream areas. However, there was a trend towards a positive relationship between ventral area gray matter increase and increase in WAB repetition scores. So you can see the p-value is 0.058, so it's trending towards significance. Okay, so I'm going to discuss the perilesional data momentarily, but I'm going to kind of take things into the right hemisphere now. So this is very new data. This is the first time I'm presenting this data, actually. So we chose to look at white matter changes in the right hemisphere. So it's been suggested that the presence and extent of white matter changes or leukoariosis might be predictive of worse outcomes in acute and long-term stroke. And so here I'm showing a figure from a paper by the Lattice group. And what we're looking at is changes in the paraventricular space. You can see kind of a halo, a ring around the ventricle space. And I'll talk can I? Oh, all right. Yeah, you can see that. Great. I'm trying to get this pointer to work. It's just not showing up on the screen. So I'm talking about paraventricular space here. You can kind of see this halo around the ventricles and also these deep white matter hyperintensities. So I'll go through the rationale of why we chose these measures, as well as how we rated these in our sample of left hemisphere stroke participants. So there's a group, the Lattice group, or the Leukoariosis and Disability Study Group, that has done extensive work with looking at how these white matter changes might predict functional outcomes in older individuals. And they found that white matter changes or leukoariosis severity, along with a history of stroke, is actually might relate to more progressive white matter changes in the right hemisphere. And again, as I mentioned before, this study by Brainwala and colleagues found that pre-stroke brain disease like leukoariosis may adversely affect an individual's ability to recover from stroke. And another study by Arsava and colleagues suggests that leukoariosis influences stroke outcome, and this seems to be independent of age, stroke severity, or infarct size. So to obtain our measures of leukoariosis, we use the Fazekas scale. And this, again, we used T2 scans from time 1 and time 2. And again, in the same 38 individuals that we had neuroimaging data on. And the Fazekas scale rates two different aspects of white matter changes. So the first is periventricular hyperintensities, or PVH. And again, that's the paraventricular space here. I'll go through each individual rating in the next few slides. But it looks for caps, or this kind of lining around the ventricles, a halo, or this irregular paraventricular hyperintensity that extends into the deep white matter. And then in terms of the deep white matter hyperintensities, we're looking at either punctate foci, the beginning of this confluence, or large confluent areas. So I'm going to show you how we rated some of the participants in our sample. So here you can obviously see a large left hemisphere stroke. And again, we're just looking at the right hemisphere with these ratings. So this person received a score of 0. So the lower the score, the better. And here we don't see really any change in the paraventricular space. And there are also no other white matter hyperintensities. So each of these are 3 different ratings. So 1, 2, or 3. Again, 3 is the most severe. So here we see caps or pencil thin lining. So you can see right at the horn of the ventricle here, and here we see the beginning of this cap. A score of 2 would be a smooth halo. So you can see an extension of that cap. And then here, I think this is the most striking difference. We see this PVH extending into the white matter there. So it's been suggested that a score of 1 or 2 might be related to altered paraventricular fluid dynamics or subependymal gliosis. And a score of 3 might be related to atherosclerotic disease. So Fazekas and colleagues noted that in their sample, their individuals that had these higher ratings tended to have a history of hypertension or congestive heart failure. So in terms of the deep white matter hyperintensities, here you can see just a couple of punctate foci, and again, the halo kind of extending around the ventricle there, but these are just looking at these foci here. To the beginning of confluence of foci, so you can see kind of the posterior area of the brain, these white matter hyperintensities here. And then again, more striking, these large confluent areas would be a score of a 3. So it's been suggested that these 2 and 3 scores might be related to ischemic damage, reduced cerebral blood flow, or atherosclerotic disease. And then some work by Valdez-Hernandez suggested that there's a greater likelihood of a score of 2 or 3 in individuals who have experienced a stroke compared to those who don't have stroke history. So to rate these, we did consensus rating between Lisa Johnson and myself, and Bree Stark helped out with inter-rater reliability. We were all blind to participant characteristics while rating these, and we trained on an unrelated sample. So you can see at the beginning we had, in terms of paraventricular white matter or hyperintensities, a number of individuals were normal, but that decreased at time 2. And then absent, score of 0 for the deep white matter hyperintensities. Only 4 individuals had a score of absent at time 1, and then only 1 at time 2. Although I will mention that the comparison between overall Fazekas scores, so that's PVH plus deep white matter hyperintensity scores, was actually not significantly different from time 1 to time 2. So looking at what these changes might relate to, we correlated the gray matter and white matter perilesional tissues in the Fazekas ratings, also controlling for scan interval. So we don't see any change in Fazekas scores correlating to perilesional gray matter changes, but we do see perilesional white matter changes are correlated with change in Fazekas scores. So as these scores increase, so again, an increasing score in either PVH or DW white matter, diffuse white matter hyperintensities is bad. So higher score, worse the white matter. We see a decline in perilesional white matter in the left hemisphere. I also looked at change in the right hemisphere white matter. So as the deep white matter hyperintensity scores increased and became more severe, and as Fazekas scores overall became more severe, that's related to a decrease in right hemisphere white matter. But again, there's no correlation between change in gray matter in the right hemisphere either. So notably, these ratings were not correlated with lesion volume, treatment, or stroke age. So looking at if these ratings related to any of the proportional changes on the WAB, we don't see any correlation between spontaneous speech. We do see, again, as these Fazekas scores increase, so as white matter or leukoariosis becomes more severe, we see a decrease in auditory verbal comprehension, repetition, and naming, and those are the WAB subscores. No significant correlation with change in overall IQ, which is probably driven by the lack of change in the spontaneous speech score. So what we did is a regression model where we used the different scores, so left hemisphere perilesional gray and white matter tissues and the right hemisphere Fazekas scores to predict change, to see which was the best predictors. So we looked at Fazekas ratings, just the PVH and deep white matter hyperintensities. We included lesion volume and also left hemisphere perilesional changes in the dorsal and ventral streams. So these are defined by the JHU atlas, and they were regions reported in Fridriksson et al. 2016. So we use these dorsal regions and ventral regions. So for the WAB-AQ, regression model was significant. All variables were entered into the model. So this accounted for 0.18% of the variance. And we see here change in PVH was significant, and lesion volume itself was approaching significance. The model predicting spontaneous speech, again, with change in PVH, deep white matter, lesion volume, and change in gray matter tissues was not significant. We didn't find anything significant for auditory verbal comprehension, although if we just did a simple linear regression with change in PVH, that would have been significant. We did find significant effective repetition, so change in PVH again, and also change in gray matter left hemisphere in the ventral stream area was also a significant predictor. And in naming, we see change in paraventricular hyperintensities and change in deep white matter hyperintensities. So generally we're seeing with these models, I think that it's changes in both left hemisphere, obviously related to lesion and surrounding the lesion, are important, but it does appear that these right hemisphere hyperintensities and leukoariosis are important to long-term outcomes in our sample. And to my knowledge, I don't think anybody else has looked at this in aphasia, although it has been looked at in stroke. So if anybody has any citations of people looking or who have investigated leukoariosis in aphasia, if you can let me know about that at the end of the talk. So when thinking about these results, and especially with the leukoariosis measures, one thing that Dufault and colleagues have suggested is that in individuals that have a higher baseline leukoariosis score, it's these individuals who actually have decreased or more severe leukoariosis over time who have more of a dementia risk. So although we're not looking at dementia, of course, here, and none of our participants did have any cognitive decline, does this progression, is there something analogous to aphasia outcomes? So do those that have leukoariosis and more severe leukoariosis at baseline, are they declining faster? So to summarize these results and go into some future directions and remaining questions, so which factors did predict long-term aphasia outcomes? We found a positive effect of exercise, especially in those with diabetes. Treatment does help in the chronic stage, and we do see a negative effect of age. We saw in the changes in perilesional gray and white matter, at least changes in perilesional gray matter were related to treatment, amount of treatment. And also it seems that perilesional gray matter was important for predicting repetition, change in wild repetition. And again, we see the importance of these leukoariosis measures. So some future questions and directions. So one thing is this is, again, the first time that we've looked at leukoariosis here, but what are the synergistic effects of these changes in the right hemisphere? Of course, we didn't look at the left hemisphere. There was a lot of variability in our sample because of the lesions. So one of our immediate first directions would be how can we rate these, the leukoariosis measure in the left hemisphere? But what is kind of driving these changes? It's been suggested that white matter changes might be related to tissue loss in the corpus callosum. So it appears that there's some global changes happening. And then another thing to consider is that some research by Maniega and colleagues suggested that the integrity of normal appearing white matter might be influenced by the presence of leukoariosis. So in rating these individuals, I did show a few examples of some of the hyperintensities that we rated. Of the other tissue that did look normal, Maniega and colleagues showed that with medial diffusivity and fractional anisotropy, that this tissue might actually not be functioning normally. So how can we kind of best capture some of these changes? And then importantly, how can we potentiate the good changes and attenuate the bad changes? So what role does exercise play? There's been a good bit of research, or some research in aphasia, and I'll present momentarily some research that Julius had presented at the ASHA conference this past year, suggesting that exercise might be important to aphasia outcomes. And obviously, if some of these brain changes are related to health status, might that help kind of stall some of the leukoariosis progression? And then also, what are the most sensitive measurement techniques, especially given that we're working with individuals who do have large left hemisphere strokes? And what's the best way that we can kind of capture some of these brain changes neuroanatomically? So is it VBM, VLSM? Nazer and colleagues have done some work with lesion evolution, suggesting that lesions do actually expand over time, although they actually suggested that, or they found in their sample, that these changes didn't affect language. And also rating scales like the Basilakos scale that we used might be sensitive to ceiling effects. So are we perhaps not really capturing some of the changes, or at least the progression of some of these changes by using this rating scale? So in terms of the question about exercise, does exercise actually facilitate long-term gains in aphasia? And this is a slide from Dr. Fridriksson's ASHA presentation in 2017 in LA. And he does show a positive change in correct naming for every hour of exercise. So this was from, this is some ongoing work from our polar sample. So change in correct naming was predicted by amount of exercise, as was change in semantic errors. And there wasn't a change in phonological errors, however, predicted by exercise. But these are some promising results. So should exercise be an adjunct to aphasia therapy? And and that maybe that's something that we should recommend to individuals, obviously with more research. So in terms of future directions, we see here, and we see from many other studies, that aphasia works. Aphasia therapy works, and even in the chronic stage of stroke. We still need more long-term prospective studies, at least to support some of the data that I just presented here today. But I think what's most important here is thinking back to the prevalence of stroke and the increasing stroke rates, especially in younger individuals, is how can we use larger studies to kind of lobby for better insurance coverage for our patients, especially if we know that individuals may change over time and that aphasia is not, there's not a plateau in aphasia. It is dynamic. So I want to leave you with this quote from Teasel and colleagues. This is from a meta-analysis looking at treatment in long-term stroke and how they suggest that they do provide evidence of treatment working in the chronic phase, but that there's this paradox where there's this impressive evidence base, and by that he means showing that aphasia treatment works long-term, but it's really contrasting with the limited optimism and resources available for rehabilitation in chronic stroke. So I think the thing that's most important to consider here is that a lot of the individuals that we work with on a daily basis are living longer with aphasia, and what can we do to really help these individuals return to their activities of daily living. So that I thank you. I wanted to thank grant funding, as well as everybody that has helped with this data collection over the past 10 years. And of course, our dedicated participants who this work would not have been possible without them. Thank you.
Take questions from the room first, and please
Okay.
repeat the question.
Sure. Question. Stacey.
I have a question about the exercise that I presented the other. What kind of exercise and how intense was it?
Okay. So the question was, what kind of exercise are participants doing, and how intense? It's self-reported, so we just on intake asked them how often they exercise, at least 30 minutes or more per day. So it's variable. So I think it would be interesting to look at intensity, of course, but it's just self-reported frequency per week.
As a comment, maybe more than a question, I would say with the exercise, you really want to make sure that you're taking into account all sorts of other factors that might correlate or predict the exercise itself, right? Because the correlation might actually, in fact, be the other way around. If depression plays a role in how well you do in treatment, it also plays a role in how much you exercise. So there might not necessarily be a causal relation.
Right, that's a good point too. And I think a lot of these factors, there's so many variables driving it, which is why I think we had 41 in our behavioral sample and 38 in our neuroimaging sample, but I think we need a lot more participants to really kind of tease out some of these results. But that is a good point. Yeah.
Could you make this presentation to Medicare and other private insurance carriers?
I would love to.
Please repeat this question.
Okay, so Leanne's question was if this presentation can be done to Medicare and other third-party payers. So, and that's why I do stress, I think we as researchers and clinicians, I think, burdens on us to really lobby for these.
So I talk about exercise again. Are we talking about exercise, normal exercise like blood in your brain, or are we talking about doing things with your brain, like tests and things like that, with that exercise?
So the question was about what kinds of exercise, just physical exercise. So aerobics, walking, biking, anything like that.
Have we ever thought about, or exercise about, like puzzles or?
Oh, yeah, that's a good question. So the question was exercise in terms of like puzzles or games, things like that. We don't have any, we haven't quantified that. I think there might be some research with some of the apps comparing like Sudoku, crosswords, and things like that versus aphasia app-based therapy. But we don't have any information on that for our sample. That's a good question.
That's another question.
Okay.
On the white matter, I hope I didn't miss it because I was making sure I kept track of your slides as well.
Sorry, I
but, so you showed, when you started talking about the white matter decline that was just without any correlation still. There was a decline over time in your overall patient group.
Yes.
And I was just wondering, what do we know about that in unimpaired non-stroke participants at this age group? Is that a normal pattern that you might see white matter decline anyway? in people
Yeah,
of that
there's,
age?
to a certain extent, some of those, a score of like a 0 or 1 is normal, and then age is typically a predictor of progression. However, other factors, it's been predicted that cardiovascular factors, so cardiovascular disease, any type of stroke injury might actually progress those changes a little bit faster than they would in the typically developing population.
We have some questions online.
All right.
Do you want to pull them up yourself? Can you?
I think I
Or is that
can.
gonna read them out to you?
Can't seem to find that. Whoop. Okay, now I can see them. A question, so the first question is from Kirana. A question about exercise. Is exercise measured before stroke or after stroke? So we actually do have a measure from before stroke and after stroke. It's the same scale. So we ask participants about how many times a week did you exercise before your stroke and after. We didn't find any effect of pre-stroke exercise. It was just post-stroke exercise that we found that one effect. So the next question was, what was the aphasia treatment given? So that's a good question. It was variable. So the treatments were treatments that had been administered throughout the aphasia lab over the last decade or so. So these ranged from naming treatment, like constraint-induced naming treatment. This included our TDCS trial, our POLAR study, which involves semantic and phonologic treatment. So we weren't able to look at specific factors of treatment here. This was just kind of general treatment. And then another key question, are the leukoariosis changes correlated with other white matter measures such as diffusivity or functional anisotropy as detected by TTI? Yes, so we didn't look at that in our sample, but in the Maniega study, they did look at FA and MD in the areas around the leukoariosis, and they did find that those were correlated or related to changes in those measures as well. So that was that normal appearing white matter that might not be normal when measured by DTI. And I think, is that all the questions I have online? Okay. Any other questions?
Thank you very much.
All right. Thank you all.